The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Dear all, first of all, I would like to thank everyone who is connected today. I am delighted to be here and chair this session. My name is Chiara Robba and I am the Deputy Chair of the Neurointensive Care section of ESICM. I am a consultant in anesthesia and intensive care in Genova, in Italy. I think that the topic that we are going to discuss today is of extremely importance because mortality on the waiting list for organ transplant is still very high. And so what we need to do is to set a series of actions aimed to optimize the organ donation pathway. I'm glad to introduce you Dr. Jan Gunst, who works as a consultant intensivist at the University Hospital of Leuven. He is an assistant professor and is a great expert in organ donation and transplantation. He is member of the Transplantation Council and he is working in the working group of organ donation of the University of Leuven. So Jan is going to provide us with an overview of the essential elements in the management of brain dead donor, which is discussed in a special issue which has been published recently in Intensive Care Medicine, the Journal of the Society. So Dr. Gunst, Jan, it's your turn now.
Thank you, Chiara, for the nice introduction. So this webinar will be on the management of the, so first I have no conflicts of interest with regard to this presentation. So the content of this webinar is the management of the adult brain dead organ donor in the ICU. So obviously there are a lot of related topics which I will not cover. Many of these related topics were published or were discussed also in a recent issue of Intensive Care Medicine, the March issue of earlier this year, which was a special issue on organ donation and transplantation in the ICU. And as Chiara said, the content of this webinar has also been addressed in a recent review article published in this issue of Intensive Care Medicine. So why is management of the brain dead organ donor important? Of course, as Chiara said, the waiting list for organ transplantation is growing. There are a lot of patients waiting on the waiting list, and over years, the waiting list has largely outnumbered the number of available donors. So optimization of the quality of the donor organs is, of course, important. So the goals of donor management are preservation and optimization of organ function in order to maximize the donation rate and the graft function after transplantation. And this can be achieved through preservation of hemodynamics and gas exchange, as well as prevention and early treatment of complications. In general, the management of the brain-dead organ donor does not substantially differ from the general critically ill patient. However, there are some specific considerations we should take into account, and these considerations are the result of the patient being brain dead. However, for many of these specific therapies, the evidence base remains low and is mainly derived from observational studies, as I will show you in this presentation. In order to understand the specific treatments of the brain-dead organ donor, it is important to have some basic knowledge on the pathophysiological changes that occur after brain death. First, the hemodynamic alterations. When brain herniation occurs, there is a rostral to caudal progression of brainstem ischemia. And in the first stage, when there's compression of the pons, there is often both sympathetic and vagal stimulation, which may lead to the well-known Cushing response, characterized by both severe hypertension and bradycardia. When brain herniation proceeds, vagal stimulation ceases, and there is an unopposed sympathetic stimulation leading to a catecholamine storm. And these two phases are also often called the autonomic storm, and these can lead to the storm of the autonomic storm by release of catecholamines, can lead to severe cardiopulmonary complications, including arrhythmias, cardiac ischemia, stress cardiomyopathy, pulmonary edema, among others. When brain death has occurred, catecholamines will be depleted and there will be sympathetic denervation through loss of neural control, which ultimately leads to hypotension. So as intensivists treating these patients proceeding to brain death, it is of course important to know these consecutive phases and to adapt treatment on that, because it's important during the autonomic storm to use short-acting drugs such as esmolol, nitrates, or nicardipine, because we know that this phase is in general short-lasting, and that after this phase, hypotension will ensue once the patient is brain dead. The ensuing hypotension in a brain dead patient can be caused by several mechanisms. The general mechanisms of hypotension and shock can be present. There may be a distributive component due to catecholamine depletion and damage to the vasomotor center, as just told, but also the inflammatory response which accompanies brain death may contribute to a distributive component. Also, endocrine alterations that may occur after brain death, such as low vasopressin, may contribute to distributive shock. But there may also a cardiogenic component of hypotension or shock. The patient may have developed a stress cardiomyopathy during the catecholamine storm, as just told, but any pre-existing condition or primary insult, if it was cardiac, could lead to a cardiogenic shock. Also, low levels of thyroid hormone, which often occur after brain death, could contribute to cardiogenic shock. And finally, the patient may also be hypovolemic, in this case often due to diabetes insipidus or to the initial injury, but also due to osmotic diuresis caused by mannitol or hyperglycemia, or other reasons of hypovolemia may be present. So as in general ICU patients, it is of course important to assess what is the cause of shock, because obviously the treatment depends on the mechanism of hypotension or shock. But the general ICU management, before I proceed, to assess the cause, the mechanism of shock, hemodynamic monitoring is of course important. There are and also to follow up on the treatment. There are no large studies on hemodynamic monitoring in brain-dead organ donors, so monitoring is largely based on common sense and also is not quite different from the general ICU patient. And obviously, when the cause of hypertension or shock is not fully clear, echocardiography can be a valuable tool. But before I will speak about the general hemodynamic management of the brain-dead organ donor, I will first speak about the potential for endocrine therapies in the brain-dead organ donor, because many endocrine abnormalities may occur after, or often occur after brain death, such as low thyroid hormone, for example, and diabetes insipidus, but also low vasopressin levels. And these endocrine alterations could of course be the cause of hypertension or shock. So the question is, should we routinely administer endocrine therapy in brain-dead organ donors? Traditionally, it has been assumed that routine hormone supplementation is indicated. It was hypothesized that after brain death, that there would progressively be a depletion of vasopressin and ADA, of vasopressin, of thyroid, of TRH and TSH, and of CRH and ACTH. And that this would lead to an endocrine insufficiency, which should then be treated on a routine basis. However, as I will show you in the following slides, observational studies have not confirmed that all brain-dead organ donors develop such central insufficiency. First, central diabetes insipidus. This condition is caused by a lack of vasopressin, and it causes polyuria and hypernatremia, as you all know. It is very prevalent in brain-dead organ donors, but not all brain-dead organ donors develop diabetes insipidus. If it occurs, of course, it's important to treat it, because otherwise it would lead to hypovolemia and hemodynamic instability, as well as hypernatremia. And both conditions are unwanted in brain-dead organ donors. So hypernatremia, severe hypernatremia, has been associated with poor liver graft function after transplantation, and therefore it has been recommended to avoid hypernatremia in organ donors. The main differential diagnosis of central diabetes insipidus is osmotic diuresis due to hyperglycemia or mannitol. The treatment obviously consists of hormone substitution by either desmopressin or vasopressin. Desmopressin is the agent of choice when there's mainly or purely diabetes insipidus, because desmopressin only acts at the V2 receptor and hence only has renal effects. The doses are noted here on the slide, but can also be found in the review article. Vasopressin is the agent of choice when there's concomitant vasoplegia. It not only acts on the V2, but also on the V1 and V3 receptor, and also has pressor effects. So therefore, it is the agent of choice when diabetes insipidus is accompanied by vasoplegia. Obviously, apart from hormone replacement, also fluid resuscitation is crucial to restore the volume status. And when the patient would be severely hypernatremic, as just told, we want to prevent severe hypernatremia, but once hypernatremia would have occurred, one could temporarily give hypotonic fluids to the patient. A second endocrine deficiency, which was traditionally assumed that it would routinely happen after brain death, is central hypothyroidism. Indeed, when the levels of the hypothalamic hormone TRH and of the pituitary hormone TSH would drop, then it would be expected that the thyroid gland would stop producing T4, or would decrease production of T4, which is thyroxine, and is in general a precursor hormone with limited biological activity. The T4 is converted to T3 in the peripheral organs, and T3 is in fact the organ with the hormone with biological activity. So if T4 levels would decrease because of low TRH and TSH levels, this could drive low T3 levels after brain death, and this is then the picture of central hypothyroidism. However, observational studies have not confirmed that these alterations occur after brain death. Observational studies have shown that T3 levels indeed decrease after brain death, but that T4 and TSH in general remain within the normal range, also a prolonged time after brain death has occurred. And these alterations in the presence of an increase in reverse T3. So these alterations actually point to non-thyroidal illness rather than central hypothyroidism. And these alterations actually completely mimic the alterations that are seen in general in acute critical illness, with a decrease in T3 and a parallel increase in reverse T3. And in acute critical illness, this is caused by an inactivation of the deiodinases that convert T4 into T3. But from a clinician's point of view, of course, the question is, should we treat low T3 levels after brain death? We know that most patients have low T3 levels after brain death, so should we treat it or not? And here, observational studies would say that, or would suggest that this could indeed be a very good idea, because observational studies have shown that the administration of thyroid hormone was associated with an increased organ procurement rate. So based on observational studies, one could think that routine thyroid hormone administration could be beneficial. However, the problem is that randomized controlled trials have not confirmed this hypothesized benefit. This is a systematic review of RCTs, and this systematic review and meta-analysis did not find any beneficial impact. There was no impact on donor hemodynamics by administering thyroid hormone, and there was no impact on organ retrievement rate. So should we routinely administer thyroid hormone or not? Or should we consider thyroid hormone or not? Well, the randomized controlled trials actually have been criticized for being too small, for being underpowered, for including too many low-risk patients. So therefore, consensus recommendations suggest to consider thyroid hormone administration in hemodynamically unstable donors, especially if instability is due to cardiac dysfunction. So consensus recommendations suggest not to routinely administer thyroid hormone, but to consider it in case of hemodynamic instability. The recommended doses are not noted here on the slide and can also be found in the review article. A third endocrine abnormality, I must say insufficiency, which was traditionally assumed to occur in brain-dead organ donors, is central adrenal insufficiency. Indeed, when CRH and ACTH levels would drop after brain death, this could drive or lead to low cortisol levels, which could then trigger an Addison crisis. However, as for the thyroid gland, observational studies have not found such central adrenal insufficiency. Observational studies have found that ACTH levels in brain-dead organ donors were in general within the normal range, also when measured a prolonged time after brain death was installed. And this unaffected ACTH or unchanged ACTH levels were present in combination with unaltered or sometimes even elevated cortisol levels. So this picture is certainly not the picture of a central adrenal insufficiency. Other authors have suggested that in some brain-dead organ donors, there may be a decreased cortisol reserve, so that the problem may be that there may be a problem at the level of the adrenal glands in a subset of brain-dead organ donors. This has been put forward by this observational study, which found that in a subset of brain-dead organ donors, there was a relatively low increase in total cortisol after a bolus of ACTH. And these authors would suggest that these patients with a relatively low increase in total cortisol could have a decreased cortisol reserve and could benefit from hydrocortisone treatment. However, there are some problems with this interpretation. It is so that this decreased cortisol reserve was also noted in some non-brain-dead patients. It was not associated with hemodynamic instability. And finally, and maybe most importantly, these authors did only measure total cortisol and did not measure free cortisol. And a recent large observational study, not in brain-dead patients, but in critically ill patients, has shown that the free fraction of cortisol actually is higher in critical illness due to a lower CBG. And this study also has shown that a relatively low increment in total cortisol is often accompanied by a normal increase in free cortisol. So since these authors did not measure free cortisol, it's difficult to interpret these findings. But from a clinician's point of view, the question, of course, is, should we routinely administer hydrocortisone treatment or not? These are the results of the prospective cluster study in France, which at first sight could suggest a benefit of routine administration of hydrocortisone. In this study, it was shown that in ICUs that routinely administered a so-called low dose of hydrocortisone, as noted here, that in these ICUs, patients were on average faster weaned from vasopressor support than patients admitted in ICUs that did not give routine hydrocortisone supplementation. However, one could question whether this is really a clinically relevant benefit, because a pressor response of giving corticoids is a known pharmacological effect which would also occur in patients not being adrenally insufficient. So it's unclear whether this is a real clinically relevant benefit or not. So, and what is interesting in this case is what are the donor and recipient outcomes of administer hydrocortisone routinely. And in this study, it was shown that the routine administration of hydrocortisone had no impact on organ procurement rate, and that there was no beneficial impact on graft outcomes. In fact, delayed graft function of the kidney was more prevalent in the group that received steroids. However, of course, we should be cautious not to overinterpret these findings. The increase in delayed graft function is only one of the many secondary outcomes, so we should be cautious not to overinterpret it. But still, this hydrocortisone study did not suggest any beneficial impact of routine hydrocortisone treatment on recipient outcomes. So should we routinely administer hydrocortisone to treat presumed adrenal failure? Clearly, there's no evidence to support that. A second reason to administer corticoids could be to protect against early allograft dysfunction, a kind of preconditioning effect. We certainly did not observe such effect in the hydrocortisone study, as I've shown you before, but some authors have suggested that to have such protection, one should administer higher doses of corticoids and predominantly administer corticoids with predominant glucocorticoid activity. So the question is, should we then administer high doses of methylprednisolone to protect against early allograft dysfunction. Here are the results of a systematic review, and on this slide I show you the results from observational studies. And as you can appreciate from the slide, the green boxes indicate the positive findings of the observational studies. The blue boxes indicate the neutral findings. And as you see in these observational studies, there is a lot of green, so it would suggest that high doses of methylprednisolone could be beneficial for donor and recipient. However, the problem is that this has not been confirmed by RCTs. In fact, when we look at RCTs in this systematic review, there was only one positive RCT. All other RCTs were neutral, did not show a benefit of high doses of methylprednisolone. And when we look at this particular positive RCT into detail, we see that it's in fact a rather small trial, 100 patients. It showed a benefit on liver graft function after transplantation, but a very similar RCT also in liver transplant patients of about similar size, similar also high dose of methylprednisolone. The second trial did not confirm the benefit. There was even not a trend towards benefit. So admitted, the second trial is also small, is underpowered to detect a clinically relevant benefit, but still the evidence from RCTs in favor of high doses of cortisone, of methylprednisolone, is low. So should we administer high doses of methylprednisolone to prevent against early allograft dysfunction? As said, there is some evidence, but the level of evidence is rather low. So consensus recommendations have confirmed that, have said that one could consider to administer high doses of methylprednisolone, but it's not mandatory because there's a lack of solid evidence. In donors that are unstable, one could consider to administer lower doses of hydrocortisone. Important to mention is that when corticoids are administered, it's important to give them after blood sampling for tissue typing, since corticoids can affect HLA expression. And then a fourth endocrine abnormality, which often occurs in brain-dead organ donors, also in generalized EU cases, of course, is hyperglycemia due to insulin resistance. There is some rationale to treat it after brain death because it has been associated with poor graft function after transplantation, and when it's severe, it can cause osmotic diuresis, and it could hence aggravate hemodynamic instability. There are, however, no RCTs in brain-dead organ donors, so the optimal blood glucose target remains unclear. So therefore, consensus recommendations recommend to prevent or treat at least severe hyperglycemia. So the conclusion for the endocrine treatments is that there is no indication for routine hormone supplementation. However, endocrine treatment should be considered in unstable or selected donors. When the problem is vasoplegia, then vasopressin and/or steroids should be considered. When the problem is cardiac dysfunction, then thyroid hormone should be considered. And when there's DI, of course, vasopressin or desmopressin should be considered. And as just said, severe hyperglycemia should at least be prevented or treated. After the endocrine treatments, I will speak about the general hemodynamic management of the brain-dead organ donor, but this part does not substantially differ from general ICU management. A first question is how much fluid we should give a brain-dead organ donor. And traditionally, there has been a hypothesis that the optimal fluid regimen may differ according to the type of organ that will be procured. It has been suggested that kidney donors could benefit from more liberal fluid resuscitation, whereas lung donors could benefit from more fluid restriction. There are no RCTs to confirm or refute that hypothesis. However, important in this context is that observational evidence suggests that relative fluid restriction is safe for the kidney, so that consensus recommendations now suggest certainly not to overhydrate patients, but rather to keep them euvolemic and probably some relative fluid restriction. And this is mainly based on this observational study, which is a prospective cohort study in organ donors, and which studied the implementation of a lung protective protocol. This new donor protocol included many strategies, or three main strategies in fact, among which one strategy was relative fluid restriction. And the authors of this observational study compared the number of donors after implementation of that protocol versus historical controls. And important, well, it was good for the lungs. There were more lung donors, but important in this context is that it was safe for the kidney as well. So it did not negatively impact on the number of donors, and graft survival was not negatively affected as well. In fact, I can't say affected because it's an observational study, so it's more association that was studied. Here you can appreciate that. Here I show you the kidney graft survival, and as you will appreciate, kidney graft survival was not worse after implementation of the fluid restrictive protocol. Admitted, of course, it's an observational study with comparison to historical controls, but still, based on this observational study, there is no evidence that fluid restriction would be harmful for the kidney. A second question on fluids is, which fluid solution is optimal? Also here, only limited RCT evidence, only one RCT in brain-dead organ donors, which randomized donors to hydroxyethyl starch versus gelatin, and which showed a harmful impact of starch on the kidney function after transplantation. So starches should be avoided in brain-dead organ donors. But for the rest, RCTs are lacking in this population, so the choice of fluid is based on common sense, is more extrapolation of what we know in the general ICU population. So in brain-dead organ donors, isotonic crystalloids are in general be preferred over colloids, no starches as said, and when the patient would develop hypochloremic acidosis, then it seems logical to choose for a balanced crystalloid. And as said before, when the patient would develop severe hyponatremia, then one could consider hypotonic solutions. The transfusion trigger is unclear in brain-dead organ donors since there are no RCTs in the specific patient population. Probably the threshold of 7 grams per deciliter can be maintained in hemodynamically stable patients, although the trigger could be higher in unstable patients with tissue hypoxia. Then the next question is which vasopressor we should prefer in brain-dead organ donors. Also here, no comparative RCTs that compared one vasopressor to the other head-to-head, so we have to rely on lower quality of evidence. And traditionally, the use of catecholamines has been disfavored because in observational studies, the use of catecholamines has been associated with a trend towards a lower survival of cardiac grafts after transplantation, and this was also when corrected for risk factors. And this was shown or suggested by this study, but also by other studies. And in this particular study, when split up per type of catecholamine, the association was only significant for noradrenaline and not for the other catecholamines. So based on this low level of evidence, one could conclude that noradrenaline is not preferred in brain-net organ donors. However, I must say this is a very low level of evidence, and there's a very high risk of bias in these kind of studies. There's a higher risk of residual confounding. But what is the evidence for alternative vasopressors? Dopamine has been put forward as a potential first-line vasopressor in brain-net organ donors, and this was mainly done after this trial by Schnelle, published in JAMA 10 years ago. And in this RCT, kidney donors were randomized to receive a low dose of dopamine versus no dopamine. And this trial showed an apparent benefit of administering dopamine as compared to the no dopamine group. However, it's important to realize that this trial is not a head-to-head comparison of dopamine versus noradrenaline. In fact, so there was no direct comparison with noradrenaline. In fact, the donors had to be hemodynamically stable before they could be included in the trial, and the large majority of included donors concomitantly received noradrenaline. But still, the trial suggested a benefit from dopamine as compared to no dopamine, with, in the published paper, a reduced need for multiple dialysis in the first week after kidney transplantation. So more than one dialysis in the first week was less prevalent in the dopamine group. However, one could question whether this is a clinically relevant benefit, because when we look at just dialysis during the first week after transplantation, which was, by the way, the reported primary endpoint on clinicaltrials.gov, but this endpoint was not statistically different between the two groups. And even more importantly, when we look at long-term allograft survival, there was no difference at all between the dopamine and the non-dopamine treated group in the RCT. Vasopressin has also been suggested as alternative vasopressor. There's some rationale to administer. There may be a vasopressin deficiency. Patients, a considerable number of patients develop diabetes insipidus after brain death. And in observational studies, the administration of vasopressin has been associated with an increased organ procurement rate. So, based on observational studies, one could conclude that vasopressin administration is useful, but the problem is that there are no RCTs to confirm that. With regard to the choice of inotrope, we also do not have comparative studies that compared head-to-head to inotropes in brain-net organ donors. So the choice really depends on the hemodynamic profile of the patient and the physician's preference. So in conclusion, for the choice of the vasoactive agent, the consensus recommendations confirm or say that there are insufficient data to promote, to clearly promote, to make solid recommendations about the ideal vasopressor of choice. However, dopamine and vasopressin can certainly be considered as vasopressor. In unstable donors, as already said, it's important to consider hormone replacement therapy apart from administering vasopressors. When we're treating patients, what are the treatment goals? Here, several potential goals have been published, but in general, these treatment goals do not differ from one publication to the other, and or may be similar to the treatment goals that we have in general ICU patients. In an observational study, it has been shown that meeting such treatment goals is associated with more organs that can be procured, but evidently this would not surprise us, I think. On the other hand, a trial, an RCT on goal-directed therapy, has not confirmed benefit from goal-directed therapy. However, when we look at the treatments that were administered in both randomization groups, on a group level, of course, there was only a small difference in treatment between the two groups. So the treatment goals, the hemodynamic treatment goals, do not really differ from the treatment goals in the general ICU patient. It is important to maintain an adequate organ perfusion, which can be achieved through maintaining an adequate cardiac output with a minimum mean arterial pressure of 60 millimeters of mercury. And the adequacy of organ perfusion can be ascertained with the classical readouts that are also used in other patients. So the conclusion of the hemodynamic management is that we should certainly prevent overhydration and aim at a euvolemic patient. We should aim at low doses of vasoactive agent, but there's no solid evidence to recommend one specific agent. And as already told several times, one should consider endocrine treatment in unstable donors. Then the respiratory management of brain-dead organ donors. In fact, brain-dead organ donors are prone to alveolar damage for several reasons, because of ischemia reperfusion injury, mechanical injury, inflammatory damage, among others. And lung protective ventilation is important in these patients, as in many other patients. And this is confirmed by a randomized controlled trial. In this randomized controlled trial, conventional mechanical ventilation has been compared to lung protective ventilation, and as compared to the conventional mechanical ventilation with high tidal volumes and low PEEP, lung protective ventilation with lower tidal volumes and a higher PEEP and other maneuvers to prevent de-recruitment, this led to an increased lung procurement rate. So it was beneficial for the number of lung donors. And an observational study has confirmed that. I've shown you this observational study before. It was the before-after implementation study, which studied the implementation of a lung donor management protocol that included the fluid restriction, but also included lung protective ventilation. And this observational study, as said, it increased the number of lung donors. So lung protective ventilation is cornerstone in management of a brain-dead organ donor, as is for general ICU patients, I think. And of course, also prevention of FAP is important, but is also true for other patients. In the last part of my talk, I will speak about nutrition, coagulation, prevention and treatment of infections, and temperature management. First, nutrition. I can be very brief on that because there are no large clinical studies in brain-dead organ donors. So consensus recommendations suggest to continue the feeding strategy as if the patient was not brain-dead. And in view of the evidence against early PN in general ICU patients, it seems prudent not to administer early PN in brain-dead organ donors. Then a word on coagulation. Also here we lack RCT evidence, but since brain death is in fact a prothrombotic state due to the systemic inflammation, it seems logical to administer thromboprophylaxis, at least in patients with normal coagulation. But there are no RCTs to support that, but it's more common sense. Also, when brain-dead organ donors would have coagulopathy, evidently it should be corrected before organ procurement. Prevention and treatment of infections is of course also important because these patients are at risk of developing a nosocomial infection, and because the organ will be procured and implanted in an immune-compromised patient. So prevention is, of course, important. But important to realize also is that sepsis and bacteremia in the donor is not a formal contraindication for donation, evidently, unless the patient develops uncontrollable shock or multiple organ failure, of course, then there can be no organ procurement. But when the patient would have a sepsis or a bacteremia, it seems prudent to wait at least 1 to 2 days after appropriate antibiotic treatment before proceeding with organ procurement. On the other hand, a febrile illness of unknown origin is a contraindication for donation. And then finally, a word on temperature management. Brain death normally leads to hypothermia because there's a loss of thermoregulation, also a diminished heat production by decreased metabolic rate and the absence of muscular activity, and through increased heat losses. Traditionally, hypothermia, or at least deep hypothermia, has been prevented or treated because hypothermia may trigger arrhythmias and hemodynamic instability, may lead to coagulational disturbances. So therefore, hypothermia has been treated traditionally. However, a randomized controlled trial in kidney donors has shown that therapeutic hypothermia with a target temperature between 34 and 35 degrees Celsius could be beneficial as compared to maintaining normal thermia. The benefit that was seen in this RCT was a reduced dialysis need in the first week after kidney transplantation. However, it's not fully clear whether this is a clinically relevant benefit, since the effects on the long term were not described. And also, there have been some critique on the trial. There was some baseline imbalance between the groups, and the primary endpoint of the study has been changed post hoc, and it's unclear when that happened. But maybe more importantly also, as said, the beneficial impact was only described for the first week, and we do not know if this apparent benefit extends to the long term. And in this context, an observational study, admitted it's a lower level of evidence than an RCT, but an observational study also has associated hypothermia in the donor with decreased and delayed graft function of the kidney. But in this observational study, there was no association with an improved long-term graft survival. So based on this observational study, the critiques on the RCT and the fear of hypothermia-related complications, therefore, consensus recommendations still recommend rather to aim at temperatures above 35 degrees Celsius, and maybe even higher temperatures in unstable donors. So the general conclusion of my talk is that for the management of the brain-led organ donor, in general, there's a lack of large RCTs to guide treatment decisions. So the treatment is mainly based on common sense and extrapolation from common sense, observational studies also, and extrapolation of studies in the general ICU population. The general management does not differ that much from the management of the general ICU patient. However, there are some specific issues, including the endocrine therapy and the temperature management. For the endocrine therapies, as said, this should be decided on a case-by-case basis, tailored to the patient, and there's no need for routine hormone supplementation in brain-led organ donors. Temperature, with regard to temperature management, the ideal temperature of the brain-led organ donor remains unclear, as just said. I thank you for your attention, And for the interested, those who are interested, here is again the reference of the recent review article in Intensive Care Medicine, where most of this information can also be found. This was published in the March issue of Intensive Care Medicine earlier this year. I will end my talk now, so thank you for your attention again, and I'm happy to answer any questions.
Thank you, Jean. Really an excellent presentation. We do have 3 questions so far, so I will start with the first one, which is the following. So, are there any thresholds in terms of dose or duration of vasopressors which might make you feel that organs are unlikely to be of good quality? Obviously, maintaining perfusion is important, but whether higher dose or duration can in fact have an adverse outcome on graft function. What do you think?
Well, I think it's a very good question, but
Yes.
it's difficult to answer it because we can only rely on the observational studies, which would indeed suggest that high doses of vasopressors would be deleterious. But I don't think, I don't think we can identify a clear threshold above which it would be. We could not proceed with organ procurement.
Yeah, I don't think that a specific threshold, actually. There are no evidence regarding the threshold, as far as I'm aware. No?
As far as I'm aware of that, there seems to be a linear, but not a clear threshold below which there's no risk, and above which there's clear increased risk. So no, I don't think we can put forward a clear threshold above which it would be too. It would be hard. It would be bad to procure organs.
Yeah, I do agree with you, Jean. So let's move to the next question. Can we do fluid resuscitation with bicarbonate?
I think, as I said, there are no RCTs in the brain dead organ donor, but I think one could consider it in a case by case basis. In fact, when the patient would have a metabolic acidosis, I think one could consider administering bicarbonate to correct acidosis. But there are no studies in this specific patient population.
Yeah. So we just fit with general recommendations, basically.
Yes.
We have, wow, you keep receiving questions, so that's great because it means that your lecture has been extremely interesting. And actually, I would have a lot of questions as well, but I will leave it to the attendees. So let's move to the next one. Would you consider thyroxine replacement in severe bradycardia of brain death, or only in cases of cardiac dysfunction?
Well, it's a good question. Indeed, in case of, I would certainly consider it, and certainly if you would think that the bradycardia leads to is not well tolerated, then certainly I would administer thyroid hormone. So yes, okay. I would certainly consider it.
And another one, who is a question from Italy, I guess. Could the use of beta blockers, such as velabitalol, during the catecholamine storm phase compromise the performance of the transplanted heart? Are there any drugs that we should avoid in the management of the 3 phases of evolving brainstem ischemia?
Well, there is some evidence that esmolol is useful during the phase of the catecholamine storm. what I think is most important is to use short-acting drugs, as I said, so that because after the catecholamine storm, then hypotension will ensue, and yeah, you don't want that you still have pharmacological effects of antihypertensives or drugs with negative inotrope activity during that phase.
Yes, excellent. Jean, is there any role of ECMO to increase organ harvest rate? Very good question.
Yes, I agree. It is. There are several aspects, I think, on this question. A first question, well, I think ECMO is certainly compatible with organ donation when there's a patient who suffers cardiac arrest and is put on ECMO, but then turns out to have severe post-anoxemic brain damage. Then the patient can be candidate organ donor, provided that the organ functions of some other internal organs is okay. So certainly, yes, ECMO in this way, for example, when using an ECPR protocol, then ECMO can certainly increase the number of available donor organs. But I think, yeah, ECMO should first be used to save the patient, of course. But when the patient cannot or turns out that he cannot be cured anymore, then as a by phenomenon, ECMO could indeed have increased the number of available donors. A second, maybe this was also part of the question, I don't know, but an ECMO circuit can also increase the number of available cardiac donors when it would be used in an NRP protocol. So then actually do not call it ECMO. NRP is in fact normothermic regional perfusion. So it is in fact not for brain dead donors, but for donors who die after circulatory death. Traditionally, in these kind of donors, the heart could not be procured because the heart, because a patient suffered a cardiopulmonary death. But recently, several centers have started a protocol of normothermic regional perfusion, whereby after death has been confirmed, there's a sternotomy performed, the supraaortic vessels are clamped, and then so that the brain circulation is excluded from the general circulation, and then the patient can be put on an ECMO circuit, but to keep the difference in this setting, we do not call it ECMO, but NRP, so normothermic regional perfusion, to make it clear that the circuit only perfuses the heart, the lungs, and the abdominal organs, but not the brain anymore. So when an ECMO circuit is used as part of an NRP protocol, then it can indeed also increase the number of available organs, because in this setting, also the heart can be procured after DCD donation.
Yeah.
So I don't know if this is the answer to the question.
Well, I guess so. And of course, the doctor who asked the question is very welcome to write down whether he's happy or not, or he wants us to go further in details regarding this question. But I will move on because we have another 3 or 4 questions. So let's see, we have still 3-4 minutes. So I'm not sure I will be able to ask you all these questions, but I will try. So feeding in the donor. So do you recommend any specific type of enteral feeding? And there is another question about feeding, which is actually, should we give food to the donor? So you can actually answer to these 2 questions together at the same time.
Well, there are actually no studies on feeding in brain dead organ donors. So the consensus recommendations suggest to do the same as if you would do it if the patient was not brain dead. I think we should not start parenteral nutrition in brain dead organ donors in view of the evidence against early PN in general ICU patients, but enteral nutrition can be started. But we do not know if it's beneficial or not. But it's certainly not a contraindication to start enteral nutrition, but there's no evidence in favor of it neither. So yeah.
Yeah, okay. Another quick question is, what inotropic drug do you use firstly in hypotension in your clinic?
Well, in general, we often use dobutamine, but yeah, it depends on the hemodynamic profile of the patient, of course. When there's a patient with right ventricular failure and pulmonary hypertension, we often give milrinone, provided that the patient does not have is not too vasoplegic. But so yeah, it's it depends on the hemodynamic profile of the patient, I guess.
Yeah. I think we have time for one more question, which is the following. So it's about the N-acetylcysteine. So the question is N-acetylcysteine eventually useful as glutathione donor to increase liver organ success, meaning outside the context of paracetamol intoxication?
So as it's a good question, but I don't think that there is. I'm not aware of studies who actually studied this in a sufficiently large trial. So yeah. I don't think there's evidence to support it.
Yeah. Good, Jean, thank you very much for answering all these questions. I think that the attendees are very happy because they are saying thank you. They are saying that they are actually happy with your answers. We have run out time, but I think this is extremely good. It's a good sign because it means that your presentation has been really interesting and it suscitated a lot of interest and questions from the audience. So at the end of the story, I think that what we need to do now is to give a couple of key messages. From my perspective, the first key message should be that we need to be aggressive, really aggressive in the management of brain dead donor. And the reason is that we need to optimize the perfusion and the function of the organs which basically are potentially available for the donation. The problem is that we don't have evidence because, as you showed, there are not so many randomized controlled trials. So there are few studies and not of very high quality. Therefore, basically, the elements and the way we treat these patients is basically based on pathophysiological reasoning, on epidemiological observation, or from ideas and clinical practice, which actually is coming from the general ICU management strategies. There are not so many differences in terms of principle with management of general ICU patients. Do you agree, Jean? But basically, we need to apply the general rules to a specific kind of patient, which is actually as particular and a peculiar pathophysiology. What do you think, Jean?
I fully agree. I think you summarized it. You summarized it very well. In general, the management does not differ substantially from the general ICU management. So, as a general ICU patient, and the specific treatments we could consider in a brain dead patient, so mainly the endocrine treatments, which should certainly be considered in patients who are unstable or patients who do not respond well to the initial therapy. So in these type of patients, we should really be consider these endocrine therapies. But yeah, for the rest, I agree. Many of the things, many of the treatment runs in parallel with the general ICU management.
Good. So, Jan, I really would like to thank you and the presentation. So, congratulations. Really a great presentation. Very, very useful. And I really would like to thank all the people who attended today. A lot of people, a lot of questions. I think it's been a great discussion. And I will wait for you for the next webinar. And thank you very much again for connecting with us.
Thank you all.